Hello, everybody, and welcome to this symposium sponsored by Tracy on quality of vision. To me, this is actually one of my favorite topics and one of the most important because we don't really pay enough attention to understanding the quality of the optics of either the lens or the cornea. We wouldn't think of evaluating an unhappy patient or even a preoperative advanced technology IOL patient without looking at their macula. And we need an OCT to look for CME that we might miss. And yet so many practices, we don't do enough beyond topography to really assess the optical quality. So this technology is one of several that allows us to look at the wavefront. And I personally have used this since 2008, and it's really indispensable. So I'm so glad we have a chance to have a discussion about that. So our first speaker is Dr. Paul Singh, who you probably know as a songwriter, but he's also a wonderful ophthalmologist. And Paul will be talking about measuring quality of vision.
Got a patient in my room, I don't know what I should do. She wants a multifocal IOL. I need to know the MTF, HOA and angle alpha, the cornea or is it the lens? I'm gonna reach for the eye trace today. I'm gonna reach for the eye trace today.
Well, that was fun. I thought we'd have some fun starting us out this afternoon. I want to first of all thank all the panelists. You guys were awesome, humoring me and sending me those videos. So that was a great time. So thanks for the opportunity. But it's fun. I tell you, we have to have some fun with this crazy world we're in now with this the web days that we're in. But thanks to Tracy for the opportunity to speak and present alongside these great faculty members. For me, I think the pillar stone and really the core of understanding patient satisfaction is understanding quality of vision. At the end of the day, that's really what it's all about, as David mentioned earlier. And to me, the eye trace is really a big part of that. And we'll get to that in a second. But before we get to that, I do want to kind of mention, I think we're actually in a stage where we have an opportunity to truly increase our volume of premium lenses. I think this is a Marketscope data that was asked surgeons out there, what do you think is going to happen after the COVID shutdown? And, I'm one of the 14% who thinks we're going to see an increase actually in premium conversions. And why? Well, I think there's a new mindset from our patients coming into our office that life is short, right? People have been getting sometimes some subsidies from the government over the last few months. And I think issues like dry eye, issues of the fear of contact lenses as being an infection or glasses. And I think lastly, which is more pronounced than I thought, more of an issue, was this idea of wearing face masks and the glasses fogging up. And I have a number of patients who actually were kind of in the shutdown, were scheduled for a monofocal standard IOL. And after we brought them back in, they're like, hey doc, can I change my lens choice now? I want to do something different. So we're seeing that. I think there's a potential for growth now post the shutdown. But what do we need? I think there's a lot of fear from a lot of our colleagues on how do I convert patients? What do I need to do to help me feel more comfortable converting patients? And it's confidence. You need to have confidence to be able to educate your patients and educate your staff, providing patients with enough value. So is it worth me spending extra money for whatever it is? And then having confidence so you know that you're picking the right lens for that patient. And then I think being able to deliver on the outcomes. And in case you can't deliver on the outcomes, how do we take care of that? And so to have that confidence, you need technology. And for me, the Biometer, the iLMaster 700, as well as the iTrace have been two core technology advances that I've had in my practice to really provide me that confidence for my patient and the education of that patient as well. And so what is the iTrace? It's a workhorse. I mean, it does everything from ray tracing, we'll get really into, of course, but it's a topographer, an autorefractor, does wavefront Ks, a pupillometer, provides us other factors such as angle alpha, angle kappa, the center of the pupil versus the center of the visual axis, et cetera, to know is a multifocal lens maybe the best option for that patient or not as well. But really getting into it, what makes it so unique is, as David mentioned earlier, our understanding of quality of vision. What is a patient seeing? And how do we correlate that to the objective understanding of the patient's complaints? And what is the best option for that patient? I think you need to understand quality of vision. And so ray tracing is really the heart and soul of this machine. And so what it does, it shines 256 lasers into the eye in less than a quarter of a second. And it understands from front to back, so forward ray tracing, how do those lasers end up on the retina? And so you can see here with a nice little diagram here, 256 sequential lasers within a quarter of a second, looking at point spread function. Also looking at the size and the intensity of those dots on the retina and where they fall. With a lot of calculations, we can understand higher order aberrations and really assess the quality of vision. But what makes it unique is the fact that it has a topographer built in. So we can separate cornea versus internal aberrations to understand what is a total aberration. So is it the surface that we should address, or should we address the cornea or the cataract itself? Is it bad enough or dense enough to offer that surgery? It also provides us things like modular transfer function, which is also contrast sensitivity. So in other words, by looking at the size of the image, the intensity of the image in the retina, we can understand what is the quality, but also the contrast sensitivity of that patient. We can also understand situations like accommodative effort, which we'll talk about later on as well. So a number of understanding and values that we can't really get with our standard machines as well. So I'm going to share with you a few cases that have helped me, and I know a number of the other panelists are going to share their cases as well, but it's not just for cataract surgery. This is a great assessment of what is happening to the image going into the back of the eye, so quality of vision. I'm a big fan of floater treatment. I do a lot of laser treatments for floaters. You see on the left there's a large massive floater in the middle of the vitreous. Well, this is one of the most common screens that we use for the iTrace. It's a patient education screen. It gives you a quality or a representative E for the cornea on the left there. In the middle is something called the DLI. There's dysfunctional lens index. Think of it as taking all those parameters, all those lens, all the 256 lasers, and assessing them and giving you a number and saying, okay, the lower the number, the less quality the internal optic. It can be the lens or the vitreous. So anything behind the cornea is the dysfunctional lens index number, basically. So a vitreous opacity could potentially cause a DLI to go down. It also gives you the total E, what they're seeing, and then also refraction, autorefraction, which is very, very precise, as well as aberrations. So it does RMS, root mean square, so you can see higher order aberrations as well as for cornea versus internal optics. So if you look at this patient here, patient had a low DLI with a large massive floater. Now you see here, it separates the cornea versus internal optics. So it's saying, hey, the cornea has less than 0.01, which is really, or 0.08, which is very low aberrations. When you get to near 0.2, whether it's internal or cornea, that starts to get significant. This patient has significant internal aberrations. So what we did, we said, let's go ahead and do a laser. We got rid of that floater. And now after the floater treatment, I could see that DLI went up to 10. And what's even more impressive is when you look at the data again here, you're gonna see that actually looking before and after, the corneal aberrations did not change at all. The internal aberrations changed significantly just by removing that floater. So we can now, using the iTrace, objectively understand why patients come in saying, well, I can see better after floater treatment, or why these floaters are inhibiting my quality of vision as well. Looking at MTF on this iTrace, the same patient here, before on top and after laser treatment, you see the MTF, the modular transfer function or contrast, improved. This arrow here at 10 cycles per degree is telling me I'm only at about 0.2 to 0.3. It should be about 0.6. After the treatment down below here, you see the arrow, we increased it to 0.6. And the refraction in these oval, the refraction didn't change. All we changed was the internal optics. So again, understanding the quality of vision was really important for me going forward with these treatments, but also to understand, is this gonna help the patient even doing the procedure in the first place? But the iTrace has also helped me understanding, are my kind of decisions correct? My perception of what is right and wrong, I've been fooled. In fact, here's an example of a patient coming up here where they came in for asteroid hyalinosis. And patients referred to me for floater treatment, whether they need a vitrectomy or a laser treatment. And after looking at the eye, look at the eye trace, I saw that the cornea, if you look up top here, says high corneal aberrations. Looking more specifically, you see here about 0.49. Anything above 0.4 is significant. So it has significant corneal aberrations. Of course, the internal was high too from those floaters as well. But we said, hey, let's go ahead and treat the surface. I looked back at the cornea and I had missed significant EBMD. And so this is a patient where instead of doing a vitrectomy, we did a corneal debridement. Patient was extremely happy after the debridement. We avoided doing a vitrectomy in this patient. Again, because the eye trace gave us that information, understanding cornea versus internal optics. Another couple cases real quick. What do we do if I have a patient's early cataract? 20/20 vision. Glare is down, bats to 20/40. Patient had a history of ocular surface disease on cyclosporin as well as other dry eye treatments. OCT of the macula was normal. So should I do surgery? Is this a dry eye issue? Is a cataract bad enough to warrant surgery? Well, looking at the eye trace on the left, you see the cornea looks fantastic, clear as can be for the representative E for the patient. You look in the middle here, the DLI is down to 5.46. And going into more specifics here, we see here that the internal aberrations, about 0.616. So this patient has no corneal aberrations really at all, and actually has mostly internal aberrations. And this is one of the benefits of the eye trace. The other thing that you're going to hear later on is the ability to educate patients. I found it so hard to educate what is astigmatism. How do you educate the patient so they understand the value? Well, what we can do also with this is say, okay, if I don't treat you for the astigmatism, just treat your nearsighted, farsighted, Mrs. Smith. And I see on the left here, see how blurry that E is? Well, look what happens when I treat your astigmatism. It clears up all of a sudden. And that is a quick understanding for the patient why we need to address astigmatism. I can show the map down below here, say, look, that's where the eye is deepest. This is why we have to take care of it. So the education part of it, which you'll hear from other colleagues, is such a valuable part of the eye trace tool. This is another screen, the Chang screen analysis, which looks at the breakdown of the RMS or the root median squared, or the different aberrations from first order, second order, and beyond, looking at coma, trefoil. And you can see here, the cornea looks pretty good, astigmatism, but the internal has a few aberrations, but really it's all internal. And again, more decision for me to say, yes, let's go ahead and address this and put a patient on cataract surgery. It also shows us angle alpha, 0.5, which is the center of the limbus, the center of the visual axis. If you have a large angle alpha, 0.5, 0.6, that's a patient that may be careful with doing a multifocal lens, because that lens, they may not be looking through the center of that optic, and therefore may have the potential for more dysphotopsia. So again, these are all the benefits. You're going to hear more from other panelists as we go along. A couple last cases here. I think it's valuable. You say, hey, I did a great surgery. I made a great decision, but what if I didn't nail the target? What if the patient's not happy? What do I do then? Well, here's a patient with a toric lens on, and a patient was pissed at me, to be honest with you. He wasn't very happy. Well, we did this actually eye trace here, and it shows this patient had residual astigmatism. You look at the cornea, looks good. The quality of the lens was great, DLI 9.6. I'm like, hey, what the heck's going on? Well, if you look here, the internal, so where my lens was sitting was at 80 degrees. It's telling me that the cornea, 83 degrees. I nailed that. I was a good surgeon. I told the patient, look how good I was. But look down here, it's saying, hey, don't go in there and rotate that lens. You're going to make yourself miserable. You screwed up the power. You didn't get the right power. So therefore now, do a PRK. Don't go in there and rotate the lens. So you can do this toric check postoperatively, even without the patient being dilated. You save yourself so much time and agony, and you can tell yourself and you tell your patient, look, I did a good job for you. Just the power wasn't quite right. We'll do a refractive surgery. We'll get rid of that astigmatism for you. Patient was very happy. And I think the last case here, it's going to fast forward here. The last case is this patient. I'm a glaucoma specialist. I still have passion for glaucoma. And this is a patient with pseudoexfoliation, lens decentered. And I did an aspheric lens, the MX60E here, which is same power from center to edge. And the question was, should I exchange a lens? Should I do a CTR? Should I sew in a lens? Well, patient was overall happy, didn't have these dysphotopsias. I said, let me just look at the eye trace. And I was able to see, wow, through the eye trace, this patient has great MTF, great DLI. The quality of the vision is great. Patient's having no issues. Guess what? I'm going to leave you alone. Forget going into surgery. You're happy. I'm not touching you. 2 years later, about a year and a half later, patient's still doing great as well. So I think at the end of the day, for me, it was such a valuable tool. After using the eye trace in one office, we got it for a second office because it's such an invaluable tool. Every patient going through a cataract evaluation has to have the eye trace before, after surgery, from a post-op perspective, to understand how they're doing, especially if they're not happy as well. And my staff is very well trained in understanding it as well. And lastly, I'll leave everybody here with the idea that don't be fooled with 20/20 vision. It's quality of vision. I don't know how many patients I've had in my clinic who are 20/20, but they're still mad. And then until I did the eye trace, I didn't understand why, and I didn't justify it for them. I used to think they were crazy. But now understanding the surface of the eye, the aberrations of the cornea versus internal, you can understand why they're not happy and what to do next as well. So with that said, I thanks for the opportunity. I want to stay on time here, but give the opportunity for the doctors to present as well. So thanks a lot.
All right. Well, thank you, Paul. That was a fantastic overview. And, you know, basically, this is like a Swiss Army knife in terms of diagnosis for the optical quality. We'll follow up now with Jesse McKee. Jesse's got some cases to present, and we're focused now on the pre-op evaluation of a cataract refractive patient. Jesse.
So first and foremost, why we invest in new technology. So we're a busy refractive practice down in Houston, Texas. And for us, we've decided to invest either if it A, improves the patient experience, or B, improves our ability to deliver better outcomes, or preferably both. And so again, a couple quick cases today that illustrate how the iTrace has helped us on both of those fronts. So the first case is a 68-year-old man with decreased vision. This guy was memorable for a lot of reasons, but first and foremost, he had 9 diopters of regular astigmatism in his refraction, just over 6 diopters in the cornea. To say he was a bit finicky is a little bit of a euphemism. He was an unpleasant gentleman. He spent the first couple minutes of the consultation telling me how much he hated docs. I don't think he had an address. He was one of those guys that kind of lived off the grid, so to speak. And the only reason he was in is because his vision was getting worse and he needed us to do something about it. So as a surgeon, I'm sitting here looking at this guy thinking, oh my gosh, 9 diopters of astigmatism. If anybody needed a toric lens, it's clearly this guy. Number 2, even with a toric lens, we're not going to be able to correct all his astigmatism. If he wants to get out of glasses, we're probably going to have to come back and do some PRK or something else afterwards. Number 3, there's no way this guy doesn't have at least some component of refractive amblyopia. He says his vision used to be good, but who knows? Are we going to do all this and maybe make his vision 1 line better? And then the last thing is, how on earth am I going to convey all this to the guy that's sitting sideways in his chair, ready to run out of the office and is already a little bit skittish? So enter the iTrace. And again, this is the DLI display as Paul described earlier. So you can see a couple things. Number 1, this ridiculously regular bow tie in the lower left of regular astigmatism. And it's certainly that helped us to facilitate the discussion a little bit. You can see the Tracy refraction showing 9.37 diopters. And then again, the DLI is decreased to 5.7. That helped us for a couple of reasons. Certainly it helped us to confirm the cataract that we saw in exam, but it also helped us to answer some of the refractive amblyopia issue. You know, I was confident enough that his internal optics have been degraded substantially, that when we remove this lens and increase his DLI to 8 or 10, we're going to make things a fair bit better for him and we're going to do him some good. If his DLI was 8 or 10, then I would think that maybe more of this is refractive amblyopia, and who knows what we're really going to get this guy. So it was helpful on a couple fronts. If we look at the Chang analysis, we see a couple things. Number 1, the relative contributions of the internal and corneal astigmatism there on the left to the total eye astigmatism on the right, which again is essentially off the charts. You can see those little arrows. On the lower right, we actually get the corneal component, which again, in terms of surgical planning is helpful. We can see that at 6.97 diopters, there's no way we're going to be able to correct this just with a toric lens. So since this guy does want to decrease his dependence on glasses, we're going to have to come back and do something afterwards. So it was helpful for me to plan confidently in what needed to happen. So again, we're going to go for the whole ball of wax. So first the cataract surgery. This is the toric planner where, again, it shows us where to put the lens, 71 degrees. We'll kind of skip ahead. Surgery goes well. Everything's perfect. He's 20/50 after surgery. And again, remember, we can't correct all the astigmatism, so he still has some residual there. We wouldn't expect him to be 20/20. The lens is essentially where we want it to be. He's happy. I'm happy. And then, unfortunately, day 2. So he calls me in the morning. He can't see. No pain or redness, but we bring him in. He's 2400 and his lens, unfortunately, is rotated about 35 degrees at the slit lamp. So this guy who normally on a scale of 1 to 10 is like an 11 is now like an 18. So he's swearing up and down the hallway, talking about how big of a mistake this was, and he never wants to come back. And I'm just literally trying to keep him in the office and keep it from running away and burning it down. And so we're trying to calm him down and talk him through the surgical plan. And so the toric alignment check was actually really helpful. So We're going to talk about this a little bit more moving forward, but this is something that we use on all our post-operative toric patients. It can be done on an undilated pupil, and it really helped him to understand that this was not a huge problem. So, you know, we were able to say, look, Mr. Jones, I know you think you're going blind, but this is what's going on. You can see that the lens, which should be about 70 degrees, has rotated. It's sitting now over at about 105. You can see there on the left. And if we just simply rotate it back, it's a simple procedure. We can get this taken care of and get you back online. And then as a surgeon, you can see all the information in the lower right. It's nice to be able to see how much the lens needs to be rotated. We get a nice post-operative refraction. And again, all that can be done on an undilated pupil. So we did calm him down. We got him to agree to let us rotate the lens. And so there's post-rotation. So we got it back to where it should be. So it's nice confirmation for the surgeon. Yes, we did what we wanted to do. But it was nice confirmation for the patient who was already a little skittish, thinking, okay, my vision's better. I can see this now. The doc's moved it back to where it needs to go. I'm on board with the rest of the plan. So in follow-up, we did correct the rest with PRK at about, I think it was 2 or 3 months. Interestingly, he had very little refractive amblyopia. We got him close to 20/20. He did allow us to fix his other eye. Fortunately, that lens did not rotate. But I do think this was a nice case that illustrated how we were able to kind of walk through a difficult surgical patient using different functionality on the eye trace, but also how we were able to counsel a patient with a difficult personality and hopefully keep him from burning down the office. So that was something I think would have been much more difficult had we not had this tool. So the second case, certainly something on the other end of the spectrum, but something we see. This is a 56-year-old woman with decreased vision at distance and near. A really nice lady, comes in wearing progressive bifocals full-time. Her uncorrected acuity is 20/30. Her near vision is terrible without correction. She's a little bit hyperopic. She easily corrects to 20/20. And she's interested in getting rid of her glasses. And she's heard about multifocal lenses. I think maybe one of her friends had refractive lens exchange. And in all fairness, we see this a fair amount with refractive practice. And generally on paper, these types of patients are pretty good candidates, but we always get an eye trace on all our preoperative evaluations. And you can see a couple things. So number one, centrally, you can see that this is indeed a clear lens. Her DLI is 10. She's got a nice clear total image on the upper right. Her tracy refraction is in green. Her angle alpha is normal. So she's starting to check off the boxes, but qualitatively, you get this sense that the corneal E is kind of blurred down, for lack of a better word, and the internal E is kind of blurred up. So if we take a look at the Chang analysis, it helps us a little bit more. So this is a little bit small, but if you look at number 6 trefoil and number 7 coma, you get a sense on the left side at the internal and corneal side of things that she's got some higher order aberrations, both inside her eye and on the cornea. And interestingly, they're serving to cancel each other out. So if you look at her total eye, things actually look quite clean. Again, she refracts easily to 20/20, but as Paul said earlier, just because somebody refracts to 20/20, that doesn't necessarily mean everything's okay. So this is relevant because if we looked at doing a lens exchange in this patient, we're going to unmask her corneal aberrations, and especially in the setting of a multifocal lens, I was really concerned that we were going to decrease this patient's overall quality of vision. So in all fairness, this is a case where the eye trace helped us to decide not to do a procedure that we thought we were going to do. In all fairness, in a refractive practice, sometimes that's just as important as doing the procedure. So I think without the eye trace, this would have been a very difficult thing to figure out. And again, as Paul said, I think just because somebody's 20/20, that doesn't necessarily mean everything's okay. You have to look at the entire visual axis. So again, in summary, no question the eye trace helps to improve our ability to deliver premium outcomes, as illustrated by these cases here. It certainly improves our patient experience. We use an eye trace for all our surgical evaluations across all offices. And quite frankly, it's something that's made us better doctors. So we look forward to kind of continuing to learn about the functionality, and it's been a helpful tool. So again, thank you, and look forward to your questions.
Great. Jesse, can you back up one slide just to the prior one? I remember in the beginning how confusing it was to look at all the bars and the numbers, and it's overwhelming to people that haven't used the technology before. So I want to just add to Paul's excellent introduction. This is about the quality of vision, and it's a combination system. It's the cornea and the lens, and that's what determines visual quality. So the lens can only do half of what we need it to do. And yet the cornea, other than it's being clear, I used to never look at it. And it took a while to realize. So MTF is really quality of vision. It's the contrast sensitivity. And we know that the cataract can decrease from that. But then we have aberrations. Lower aberrations decrease from that, but that's sphere and cylinder. We can correct that with glasses, can correct it with a toric lens. But higher order aberrations are aberrations or irregularities that we cannot even correct with glasses, and yet they subtract from the quality, the overall contrast sensitivity. And RMS is the unit that we measure those higher order aberrations. And so that's what we're looking for. And for the first time, we can quantify it. So when I first got this in 2007 or 2008, I worked with Tracy because, you know, as a cataract surgeon, I just want one sheet to look at. And so here is the cornea aberrations, and here's the internal aberrations. It could be the posterior capsule, it could be the cataract, it could be the vitreous. And then this is the total when you add the two together. And so this is the topography, obviously. And then we have refractions, we have refractive power, which Carolini will go over. But it's a snapshot of kind of where are the problems coming from. And I think what we're trying to do today, we're going to talk about pre-op. Is it the cornea or the lens that's causing the patient's problem? Post-op, why is the patient unhappy, even though their vision isn't maybe not that bad? And then Carolini is also going to talk about the use for a toric. So let me just ask the panel, you know, multifocal lens patients, we don't have any margin for error. What are you actually looking for in a display like this? Let me ask Arthur or Carolini.
I'll go so long, David. I'd be looking at the level of higher order corneal aberrations to make sure that they don't over normally 0.4 microns. The other thing I try and get a handle on is what the angle alpha is, what the difference would be from the center of the limbus versus the visual axis. If that's more than 0.5 of a millimeter, I'd normally be a little bit hesitant to use a multifocal IOL. But mostly to two things: make sure the cornea isn't the cause of the problem, and also it's very nice to show the patient that in fact the lens is the cause of the problem.
And let me ask Carolini, you know, you and George have really pioneered this idea of looking at lens aberrations. And so often, you know, I'm seeing someone and they're complaining and the cataract doesn't look that impressive. And yet I know in the past we've done surgery and the patient goes to 20/20 and they're happy. So how does the aberration profile help us in that patient?
Yeah, no, it's a great question. And we did a lot of work on the aging lens, right? We know that patients, of course, they lose accommodation. We see changes in scatter, high order aberrations, and then opacity. Right, prior to see, you know, opacity, like NS cataract, cortical changes, or like that huge PSC cataract, we see a lot of changes in higher order aberrations, especially spherical aberration with nuclear sclerosis. So the eye tracing, because again, we now know if the aberrations are coming from the cornea versus the lens, is a really great resource, even to show and explain to the patients, right? We should not do LASIK. You may come back in 1 or 2 years unhappy. We should definitely address your lens.
Mm-hmm. Jesse, when you see corneal aberrations, do you actually discuss that with the patient preoperatively?
We do. So, you know, I think the case that Paul presented earlier was relevant. We see several patients where the corneal aberrations are a little high, even though they have cataracts. And so oftentimes we'll work to optimize that preoperatively. And I think it really helps to facilitate that discussion where we can sit and, you know, I think this gets overlooked, but the DLI screen is a really nice premium screen in a darkened exam room, just to sit and explain to patients very simply that, you know, yes, you have a cataract, but your cornea is causing trouble too. And if we get this nice and clear, you're going to have better results. And so that really helps us to facilitate that preoperative optimization of the cornea.
Thank you. And Paul, do you do this on every cataract patient, or you just do it when they might want a multifocal or advanced technology IOL?
Every patient, because even if you have a standard monofocal patient, they have expectations regardless. And so everyone expects premium outcomes without the premium lens. And so, if you have someone like Jesse mentioned, corneal aberrations and expectations, hey, your vision may not be 100% afterwards, or we have to address the surface before we do surgery. So for whatever reason, giving us a better understanding of the optical system allows us to educate the patient and manage the expectations going forward.
Yeah. That's excellent. It's really no different than you want to diagnose an epiretinal membrane preoperatively, not only because of what lenses you might not use, but you need to factor that into patient expectations, as you said. And before we started doing this, I routinely, of course, would miss issues that they show up afterwards. And of course, it's always tough coming back then and trying to explain then that they have a problem in their cornea. So we'll move on, and Carolini's going to talk about next astigmatism. And then our last section will be on using this to diagnose post-op mysteries. Why is the patient unhappy? Carolini?
Thank you so much. And thank you for joining us today. This has been fantastic. I really love the video, and I want to thank you, my fellow resident and medical student. They were great helping me with that. I don't see my error here to pass the slide. Oh, no, it's working. So yes, I think again, a toric lens these days, I think as a refractive cataract surgeon, we really need to address astigmatism, right? To be able to offer our patients the best quality. And the iTracy is fantastic. Again, this screen is easy. I remember when I first got the iTracy many years ago, it has a lot of information I use in my practice for research, but also some of the screens and the software is so easy to show our patients, for example, in this case, that the problem and the aberrations is coming from the lens with opacity and the DLI. Here, the same patient, when we look at the cornea, this is what the patient will see with a standard IOL, without the lower order aberrations correction, without correcting the astigmatism. And as you can see here, there's a little glass. So this will be without astigmatism correction. And then you can show your patient, if you just use a toric lens, you have this high resolution vision. It's like buying a high resolution TV. So this is definitely very helpful to show our patients what to expect after astigmatism correction. So not all K readings are the same. It's important to remember, when we're looking at manual keratometry, and even the SIN case, we are measuring only 4 points at 3 millimeters. Refractive keratometry is better, but again, we're looking only at 3 millimeters. Wavefront keratometry, it's only available in the iTracy. And basically, it calculates the steep power and nexus based on the Zernike fit, from the entire topography data within a 4 millimeters circle. So this is really important. And again, if you have an iTracy, you can look at the numbers. In this case, with SIN case, a SIN case is measuring 1.2 diopters of astigmatism, and our wavefront case is definitely showing higher astigmatism, higher magnitude, and actually a different axis, at 4 millimeters. So we mentioned a little bit optical alignment, and I like to make optics easy. I love to teach the residents on optics, but let's talk a little bit about angle of alpha. What we're looking here, VA is our visual axis, or first Purkinje. PC is just the center of the pupil, and the yellow dot, the optical center, is just the limbal center. Angle alpha is this distance from the visual axis to the optical center. And the angle kappa, now we're calling like a chord, right? We're measuring mostly a chord, is the distance from the visual axis to the center of the pupil. And why is this important? When is it important to know this distance, from the visual axis to the pupil center, or angle kappa? This is helpful for intrastromal rings, for refractive ablations, contacts, SMILE, because we know, for example, patients can present with dysphotopsias after a decentered ablation. So the angle alpha, it's useful for internal corrections. Remember, angle alpha, again, is that limbal center. We place a lane, IOL, inside the capsular bag, right? That's why this is important. And then again, it's this distance between the limbal center to the visual axis. So important for IOLs, ICLs, pinhole IOLs that are coming up, and multifocal centration, and a toric IOLs, and we're going to see why. And I really love these slides. But this is what we see. Again, the green, pupil center, blue is our OC, the optical center, and the red is our visual axis. Here's pretty significant, right? So, and this is a patient that has with the rule astigmatism. And does it matter for this patient if this patient is having a toric IOL? Well, for with the rule astigmatism, remember that the power of a toric lens, it's 90 degrees away, right? The power of the toric lens is in the horizontal position. So for with the rule, actually doesn't matter, right? Because the power is there, right? Despite the angle alpha. However, in patients with against the rule astigmatism, it matters because if we remember again that the power of this lens is 90 degrees away, so this patient will probably be undercorrected. And if you remember that Prentice's rule, right, the prismatic effect, you may expect some prismatic effect here. It's something that we teach our residents. But this patient may not do well, for example, with a multifocal toric lens, right? Because you may have some residual against the rule astigmatism. So this is very helpful in terms of toric planing. We mentioned the toric check. This is great. We don't need to dilate our patients. And actually, the software tells us what to do. In this case, we probably need to rotate this lens 38 degrees. And then we expect a 2.79 diopter change in cylinder power. So this is very helpful. It's just a quick picture without dilation. So, and then again here after IOL rotation, this is perfect, right? So we don't need to go back and rotate. There's just a 0.15 diopters changing in cylinder power. So, okay, so you have a patient, that patient has astigmatism and comes in for cataract surgery. What to do and how can you use the eye tracing to help us? We have all this technology, but again, it's something that can help us to plan surgery. It helps us to talk to our patients. One, we need to choose the best case, right? We need to now consider the PCA, posterior corneal astigmatism, all the work done by Doug Koch and again, the Baylor nomogram. Plan the axis, right? And we're going to show some pictures on imaging in iris imaging tool to verify alignment and then, of course, check our results post-op. So this is a great case here. If I'm just selecting SYN case that again uses 3 millimeters, the best lens will be a T7. However, when I change to wavefront case, the software here is suggesting a T8. And then remember, you want to make sure you also include the PCA for cases, especially in patients with against the rule astigmatism. Remember, the posterior cornea acts as a minus lens, and that will add against the rule astigmatism. So we always need to take the PCA into consideration when planning toric IOLs. So then here's our final toric IOL power. So then what to do? You review your surgical plan. You can print this, take to the OR with you, but also, if you don't have intraocular aberrometry or some of the other fancy devices, the eye tracing can help you by using iris imaging to mark the axis, or sometimes I really like to look at some limbal vessels, make sure you're gonna align based on some anatomical landmarks that are specific for that patient. So what you do, you just print your screen, you save, and you can take the plan with you to the OR. So then analyze your post-op results. In this case, again, it's a patient with against the rule astigmatism. You see the axis, the corneal axis at 13, but the IOL is at 44 degrees. What happened? My patient is not seeing well. Was it the lens that rotated? The surgeon didn't follow the nomogram? Was it SIA, or the surgeon placed the lens in the wrong place? What happened, right? But again, the answer is right there. So if you rotate the lens 30 degrees, you can fix 3.6 diopters of astigmatism. So this is great. But in summary, you can use, you can improve your toric results. Number one, for early cataract diagnosis with the DLI screen. You can remember the wavefront case are great and reliable with most accurate K readings. Precise lens location. You can use the Osher Ring screen software and look at every post-op toric on iTracy without dilation. That will definitely improve your outcomes. Thank you very much.
Great, excellent, thank you. Let me just ask the panel, how many of you use the toric IOL check, and is it accurate enough that you don't even have to dilate the patient and look at their axis? Jesse?
We use it on most all of our post-operative toric patients. You know, in all fairness, we're a busy practice, and once in a while somebody's seeing 20/20 and they sneak through. But that being said, it's even useful when we see that the lens is where it should be. It's nice confirmation for the patients. So we use it quite frequently. And again, not having to dilate the patient is a really nice thing.
Yeah, I think it's also important to realize by not having to dilate, you can walk into a room. So sometimes if I have a patient, like the text will tell me, yeah, patient may not be quite as happy. You look at the iTrace going before you go in there, and then you can kind of know what to say when you walk in, which is, I think it really arms you with that information before you talk to the patient.
Yeah. Excellent. Let me just, a different topic. You know, when I was a resident, my least favorite subject, like many, was optics. And how did you all learn how to utilize this, you know, a massive amount of information? And how do you recommend someone who's new to this? Will it take them long to get to a functional level? And how will they learn how to use all of this? Is there a YouTube video for this?
David, as a refractive surgeon, coming from that end, it was quite straightforward because you learn all of these things with refractive surgery. But I think the way it's been put together with the DLI and in fact with the Chang analysis, even if you're a cataract surgeon per se, and you haven't been exposed to this, it's a very, very intuitive tool to get used to. So I think Tracy have done a very good job of making complex optics understandable.
Yeah, I would just say from a glaucoma, I mean, look, I'm a glaucoma guy at heart. So you're talking to a guy who's always messing around with the optics. And I think, yeah, to our point, I think that they've simplified enough where you know some basic parameters. If you have a certain amount that's above in the cornea, be watchful. The red bars show a lot of higher aberrations, watch out. So they're very simple, I think, some of basic paradigms and tools that you can use to make those decisions without having to go in depth with the understanding of the optics itself.
Good points. You know, Tracy's done a good job. They have something called iTrace University, and what it is a collection of lectures and talks. And actually, if you go on our 20 Happy website and find under the sponsor list, Tracy, there's some links there that give a sample of that. I wish I had those back in the beginning. It would have made it a lot easier. Well, we've talked about pre-op, we've talked about toric. And where I have found this unbelievably helpful is when someone's unhappy post-op. And the very first thing we do, whether it's a consult or my own patient, is we get the iTrace. And so I'm going to have Arthur go next, and then I'll end with some cases that I'm going to test the panel with. Arthur.
Thank you, David, and thank you to Tracy too for this opportunity. So these are my disclosures, and I want to make it clear that I'm not a consultant for Tracy, but I love speaking about this device because it's really a partner in my practice. It's something that really adds value to my practice. So this instills confidence when patients are unhappy. So if you find a patient who's unhappy following their surgery, empathize with them, tell them, we'll get to the bottom of this, we're here to help you, reach for the iTrace, put in a few lubricant drops, and then use their data and their simulations to separate corneal versus lens aberrations and assess IOL tilt and centration with the eye trace. So a recent study by Rupert Menapace from Austria showed that most toric IOLs rotate in the first hour post-surgery, and normally by 5 to 6 degrees, or on average by 5 to 6 degrees. The best time to measure is 2 weeks. The best way to measure is with the eye trace toric check. The best time to rotate is within 2 to 4 weeks following surgery. Don't use viscoelastics when rotating. Simply open the leaves of the capsule where the haptics are with BSS, and then the area where they need to go to, but don't open for the full 360 degrees. I'm going to share a few case studies. Here's a patient who 48 years old seeking presbyopia relief, had significant astigmatism, so needed a toric multifocal, and a clear lens extraction was planned with a Symphony toric. The patient was unhappy post-operative, however, and a consult was requested to see if we could help with this patient who was complaining of dysphotopsia. So the first thing to do is acquire good, reliable data on corneal topography and wavefront using the eye trace. Compare several measurements to ensure that the data is reliable. Compare the manifest versus the eye trace refraction. Locate the source and the type of higher order aberrations. Assess the optical alignment of the lens by using the eye trace on the dilated eye, using the radial ruler to confirm optical center of the lens, and then use the toric check to assess both alignment and the power of the IOL's cylinder. So here we're looking at the corneal topography. The two scans coincide very well, so they're validated. Do the same thing on the wavefront. Again, they look identical, so there's validation. Anytime the refraction appears in green, you know it's a very, very accurate refraction. But go back and look and see how the tracy refraction compares to the manifest. And if they look very similar, you know you've got good diagnostics. And the DLI we've spoken about quite a bit, but this is a very useful tool for patient education. And many times I'm educated by it too. And the Chang analysis we've spoken about too, I find this particularly useful in helping me identify where the problem is lying. And then on a toric alignment, we've seen this quite a bit today, but I want to show you two things there that are important. You can see the IOL is currently at 110, should be at 139. The tracy refraction tells us there's astigmatism residually of 1.3 at 83. And if we do a 29-degree rotation, we're going to bring about a 1 diopter change, which would leave us with basically an emmetropic eye with a 0.23 astigmatism. So we know in this case, we got the power right, and the only problem was the alignment. Using the ruler, we can also see what the angle alpha is. The red cross is the visual axis, and the yellow cross is in the center of the yellow ring, which you've put onto the IOL. You can attach it to the rings, and you can see what this chord length is. And when it's more than 0.5, it could be a problem. So in this particular patient, a toric rotation would eliminate residual refraction. We've seen that. So the toric check is showing that the cylinder is correct. It's just the alignment that's out. But dysphotopsia may still be noticeable even if the patient is plano, and rotation obviously won't resolve that symptom. And then a very large angle alpha, in this case more than 0.64, is possibly a contraindication for a multifocal toric. And toric lenses can sometimes move. They are forgiving with larger central zones, but cannot overcome big alignment errors. I want to show you a different case. This is a patient with a Symphony toric. Again, a 38-degree rotation is required. You can see in green above that the astigmatism currently is at 3.87. And if this rotation was done, it would reduce the astigmatism by 2.79, and the predicted post-rotation refraction is 0.99 astigmatism vertically, which would be acceptable. In this particular case, however, the surgeon decided instead to do a PRK, and this led to an irregular cornea, which you can see on the right over here. And there's still a small misalignment, but if you now go and rotate this IOL by the 7 degrees required, it's going to make no difference. So really, the right choice over here was to rather rotate the IOL rather than to do a PRK. Here's another patient with previous surgery, a 53-year-old female, had RK 25 years ago, presents now with reduction in vision, and my colleague makes a diagnosis of a posterior subcapsular cataract. Corrected vision is 20/20 minus 3 in the right eye, 20/30 minus 1 in the left eye, but very symptomatic with glare and halos. So we called the patient back what's playing the bigger role here? Is it the descended small OZRK, or is it this early cataract? And so here you can see on Scheimpflug, the optical zone from the RK. On the left eye, you can see it's decentered. This is confirmed with placido disc on the right and the left eyes. And now on the eye trace, on the right eye, you can see the corneal contribution with all this ghosting. You can see the internal optics aren't that wonderful either, but there's a warning saying there are high corneal aberrations. Be careful about how you interpret the internal aberrations. And now you'll see, I'm going to put up 4 images of the right eye, and every single time we see the same issue. So this is validated data. It's really telling us what the issue is. And on the left eye, the same thing. Look at this huge aberrations coming from the cornea, and it's repeated on multiple scans. So I can now with confidence tell this patient, and they've seen this themselves, they can see that the problem is the cornea is currently playing a much bigger role than the early cataracts. So the best option here is to first do a topo-guided PRK. Let's regularize the cornea and then review again. And that's exactly what we planned. And then the last case I want to share with you is a previous case of an incisional keratotomy. Patient comes in with DLS grade 2, and the eye trace shows that the right eye cornea is the bigger issue, and on the left eye, it's more internal. So here's the placido disc of the right eye, of the left eye, and confirmed with Scheimpflug. It's very, very similar images. So we know there's corneal involvement. The eye trace shows us for the right eye that the right cornea is the problem, and the lens is actually quite clear. And for the left eye, shows us that the cornea, despite the aberrations we're seeing on the other devices, is optically actually quite clear, but the problem is in the lens. So we go ahead and we do a cataract surgery for the left eye, and the patient's very happy. 9 months have passed in the meantime, thanks to COVID, and she's coming in now for a second eye, which we decided 9 months ago is due for a topo-guided PRK. But things tend to change with time, so we repeat the eye trace. Topos look exactly the same. There's no change on the topo, but the eye trace now shows us that, relatively speaking, on this eye, the lens is now a bigger problem. So of course, in the last 9 months, the lens has become the bigger issue. And the right eye is the internal optics of the problem. And again, this is on a repeat scan, we see the same thing. So we go about doing the right decision, and rather going to do the cataract now, and we're going to do a topo-guided PRK as required post-operatively. So eye trace confidence, I like using the term eye trace confidence because it gives me confidence. It gives my patients confidence. The eye trace gives me confidence that my patient understands the issues. The eye trace provides objective data that fits the subjective experience of the patient. The eye trace gives the patient a voice. And the eye trace makes complex optics understandable. So you can see why I am very happy to speak about this device. I really regard the eye trace as a very senior colleague in my practice who knows a lot more than I do and can guide me when I'm not sure exactly what to do. So thank you for your attention.
Excellent. So I'm going to follow that excellent talk with some cases, and I'm going to try to see if the panel can use the data to figure out what's going on. So the panel has not seen these cases at all. So Drew, you can pull that up. Now we have some questions from the audience, so we're going to run over time at the end of this and try to go through the audience questions for those wanting to stay on. So I also have no financial interest in the Tracy. So panel, this is the first case. It's a patient who's unhappy and they've already had a YAG capsulotomy. And this is the typical thing, you know, I was having washed out vision and waxy vision. They assured me that this would improve over time. This patient waited a year and the problem didn't occur. Another doctor, you know, cautioned, but then another one said, go ahead and do the laser. So they do have the YAG capsulotomy. Here's the edges of it. So in this multifocal, they have a good refractive outcome, but they're not happy. So the patient is now getting a fifth opinion with us. And so does anyone on the panel just want to comment first of all on, we'll show this screen and the simulation here. This is basically higher order aberrations showing that even with glasses, the quality, so the left eye is phakic. You can see the difference there. And so this is the left eye. This is the phakic eye. And just to show again, this is the total wavefront, but then this separates what's coming internally. And this patient has a early cataract and then the cornea. And then this is the affected eye with the IOL. And anybody on the panel want to talk about what they see here?
So David, you're certainly seeing a lot more corneal aberrations on the affected eye than you are on the other eye. And even the topography is showing irregular astigmatism. So I'd love to see what the DLI looks like over here, and I'm sure we're going to see some aberrations in the cornea. The way I would approach it is based on the DLI, because that way the patient's with me on the topic, and we'll see which is playing the bigger role. And then either go topo-guided PRK or look to see what's happening internally. Internally is not always just the lens. It could be floaters, could be the posterior vitreous detachment.
Yep. So if we go back to this screen, I don't think I have the DLI screen, but you've pretty much gotten it, Arthur. I think that, you know, the difference in the two eyes is really in the cornea. And what is nice, I mean, do you guys have any guidance on how much corneal aberrations are acceptable? In other words, if you see this, how do you know when you have corneal aberrations preoperatively? I mean, this topo certainly doesn't look like as bad as the ones you were just showing with the RK patient. It actually looks pretty good. And so I was actually a little surprised to see that much. But how do we know what is too much to put in a multifocal lens?
Yeah, this is a great question because we know that the aberrations, they can present with different visual symptoms, right? For example, spherical aberration, if it's too much, patients, they see halos around lights. Coma is definitely very detrimental to quality of vision, especially with diffractive technology. And remember, aberrations are pupil dependent. You know, when you talk about higher order aberrations, I think for a 6mm pupil, if I see especially coma greater than 0.4 microns, I think is when it's a red flag for multifocal IOLs. In terms of total HOAs, again, a 0.4, that will be my cutoff for these patients. It's interesting, when looking at the picture, we see a little bit of capsular phimosis. I was curious about the angle alpha for this patient, right?
Yeah.
I don't know if it's just a dilation and see if that was within normal limits.
It wasn't, it didn't jump out, so I don't think that was it, but that's one excellent question. And you said it. I mean, I think the one problem with just topography is it averages the higher aberrations over 6mm. And yet I don't have any patients walking around with a 6mm undilated pupil. And the aberrations really shoot up as you go peripherally. And to me, the most important thing about the eye trace is you can measure the aberrations in their undilated pupil. And you see this pupil's 4, this one's 3.5. This patient just has large pupils. And so this cornea is going to cause way more aberrations than we expect, I think, because of the large pupil. If it was a 2mm pupil, it would be fine. And so I use this really to counsel the patient on why, despite the open capsule, we should take out the lens. And the thing that I always see with these is the patient is just so grateful. Again, I'm the 5th opinion here. And I'm the first person to say, you know, with your cornea, this multifocal just isn't a good fit. And I think we've all learned that what you don't say to an unhappy patient is, I did perfect surgery. You're 20/20. You should be really grateful. You know, this is a great technology. All the other patients like this lens. And I think just to have something objective, because in your mind, you're kind of going, is this a fussy patient? They're just not happy no matter what. And to be able to see something objective, you know, tells you that it's really, they're really right. They have that. So I went ahead and did an IOL exchange and the patient was happy. So here's a patient who's 5 months post a lens implant. This was actually done back in September, and this was the initial post-op. So it's the left eye that had a lens, and she had a good result initially. This is pre-op, and then post-op. Okay, she had some residual astigmatism. It was not a toric lens, but she was happy. 20/30. There's a little bit of CME. It was treated, but then she came back, and her vision really dropped. And the surgeon saw that the loops of this lens might have been in the sulcus. He took her back, and the capsule had contracted, and he decided, well, I'm going to leave this alone. And so I have to see her, and she's actually leaving for the Bahamas in 2 weeks. So we get her in, and this is now the cataract on the right. This is her vision on the left. So with correction, it's dropped to 2400. Now, what is going on here? And that is the lens. So it's an Acryos. So it's not a multifocal. And there's no CME on her OCT. So we've got really a major visual problem. And you can see the lens is a little rolled up there. So take a look at this. And does anyone want to take a crack at this one? Paul, you were silent on the last one. So like the teacher, I'm going to call on you.
Hiding away.
Digital classroom.
Yeah, well, no, I mean, you look at that internal, it looks like the lens is tilted there, and you can see that astigmatism in the internal HOA pretty high.
Yep.
That's even for someone simple like me, that looks like a big bar.
Yeah. So the bars that are not high order aberrations are astigmatism. So here you can see the corneal astigmatism. So that's a lot of corneal astigmatism, and this shows you, in microns how much. So that means her lens, in my simple view, is 2.5 times as much astigmatism as the cornea, and that's a bad cornea. And then you can look over here. So this was in February. So this was the refractive map. That's the cornea. So she's got a lot of cylinder, probably could have used it. But look at the refraction now. So this is an objective refraction. So 8 diopters. So what would you do? So the question was, can we just leave it and treat her astigmatism with, keratofractive surgery, or, so, also notice that, well, we can kind of do a toric. Here's the DLI. So this is a tilted lens, but it's also creating a lot of aberration. So it's more than just induced astigmatism. This is a little bit like your case, Jesse.
Yeah, that's kind of a version of my case on steroids here a little bit. Certainly the DLI is decreased substantially there. I think with the amount of astigmatism you're seeing, at least in my opinion, I think going back and, say doing something to the surface would essentially be like, putting a Band-Aid on a broken leg. In my opinion, this probably needs to be addressed at its source with a lens.
Yeah. And then showing the toric, it's basically saying rotate it, and we're going to get a 4, almost 5 diopter change. So the only problem is it's not a toric lens, and rotating the lens isn't going to really help. So so here's the lens, and the capsule is contracted, and the surgeon kind of tried to go in to push these haptics in and couldn't. But it sounds like you're voting to go back there. So to save time, I'm going to show you how fibrosed the capsule was. There's a zonular dialysis, and when I eventually get that out, I'm actually going to try to put a toric in, even though the bag is pretty loose and we're pretty far out there. I think that the DLI was helpful here because if the case wasn't quite so extreme, you could consider just eyeglasses if there was a misaligned toric that you didn't want to move. But when you're seeing higher order aberrations, again, I just have to remind myself that is not corrected with glasses. So what do you think is going on here? The lens, as you can see, was sort of squished, And I think it was not only inducing regular astigmatism, but also irregular astigmatism, just bad quality optics. And that's why I went ahead and did my best to explant that. And because obviously you'd rather not touch this and you'd rather treat it with glasses, or we couldn't treat it with a contact, and we couldn't treat it with keratorefractive surgery. Any comments from the panel?
Well, I was just going to say, I think there's a nice discussion that we have all the time about the tilted lenses and how a number of our patients do have tilted lenses. And it's hard for most of us, just by looking at the lens, to understand the relative contribution of that to the quality of vision for that patient. Now, this is an extreme case, of course, but you'd be amazed at how many patients may come in where the vision's not quite there, and you do this, and look, you see that internal HOA or even astigmatism, lower aberrations being higher than you think, and that could be because of tilting of the lens as well. So I think it just gives you understanding more than just these extreme cases, even in the more moderate patients who have a tilted lens.
Excellent point. So this is post-op now, and she actually went back to the Bahamas, and with COVID couldn't come back until we reopened at the end of May. And so now you can see what a toric lens should look like. And you see this is red and the cornea is blue, and it cancels it out here on the cornea. And then the refraction is much more reasonable now in terms of her auto refractor. There's the internal, and then there's the total. And this is just showing the two pre-op on the top and post-op on the bottom. See, the cornea is very consistent, but obviously the higher order aberrations induced by the compression on the lens. And now using the toric IOL check, I can see that, rotating it might change, but obviously we're not rotating it. It was, I believe, a T6 that I put in. So we're not directly on, but that's as close as I was going to get with that bag. So it was a T6. So she's very happy with that. And again, it helped me to force me to think about doing that. This is a case, just like you said, Paul. This patient had a PC rupture. They put the lens in it decentered. So they took it out and put a new one in. And here is the refraction, 20/40, but the lens is actually pretty well centered. Let's see if we can move the screen up. But you can see that this, again, is not a toric lens. It's a monofocal, and it's induced some astigmatism there. We don't see a lot of higher order aberrations, but so we still have the choice of doing glasses, of course, but it's just showing that this lens, even though it was a fairly small amount of tilt and it was a monofocal, was inducing that. This is a puzzling one. We're using the light adjustable lens. So this is pre-adjustment. You can see the refraction here. They were hyperopic. Here's their astigmatism. So we did an adjustment. And then this is the post-op refraction. We made them a little myopic. Well, that's pretty good. Then they came back after that adjustment number one for their next adjustment, and their vision had plummeted. So you notice that prior to that, we have no problem in the lens, no problem in the wavefront. And then after the second adjustment, which is either neutral or designed to go after maybe a little bit of sphere, we had a big problem. And look at the refraction now. They've now shifted to -5. So what the heck do you think is going on here?
This is a very interesting case here, because we usually see coma with tilt and decentration, right? Or really, yes, if you're really measuring with the new, Gatnell's polynomial, sometimes astigmatism, you can measure, higher order astigmatism. Sometimes you can measure a little bit with coma in Zernike.
So this lens, just so everyone knows, it's a 3-piece silicone lens, and it's totally in the back. And the patient, of course, said, ever since that last adjustment, I can't see. But you're right, there's a ton of coma there and a ton of spherical aberration. And for a 3 millimeter pupil, these numbers are off the charts. This is not a dilated pupil.
David, I'd be wondering if the patient wore their glasses to protect them from ambient UV.
Right. So the patient says they've been pretty good, but this is actually my partner's patient, and his assessment of the personality was very likely this person was not really compliant and religious about wearing the glasses. So the decision was made to take them back to the operating room. And with the dilation here on the table, can you see what's going on here? There's a little button.
Yeah.
So, and where does that button correspond to?
Pupil size.
Exactly. So this is an example pretty clearly, I think, of what happens if the patient doesn't wear the UV glasses. They get polymerization. The molecules come into the center. You get a huge myopic shift. So it would have been a great treatment for +5, but it wasn't the one that was desired. And you can really see that little button there. Very good. You got that. I'm going to end with this one because we see unhappy multifocal patients. This woman had LASIK. She then had just in one eye a Restore. It's an older case. The vision wasn't clear, and no wonder she's got residual astigmatism. And so it was recommended that she have a PRK touch-up. Everything else was normal. She didn't feel comfortable with that, so she's trying to get a second opinion. And here is the IOL. It's centered. You can see from the Purkinje images. So the question is, she's not happy. Do you go ahead with the PRK or do you take it out? So this is looking at the wavefront map. Again, the right eye has minimal cataract. The left eye has a lot of higher order aberrations. Again, not corrected with glasses. So this is not the astigmatism. And then, the software highlights some of the visual complaints from those higher order aberrations. So let's take a look at her cornea. This is the right eye that's post LASIK. There's the ablation. Now she again has big pupils. Undilated in a darkened room, her pupils up to 5 millimeters. And then there's the total wavefront comparing the internal and the cornea. Why is she getting some internal ones? This is a phakic eye. Well, she does have a little cataract, in that eye. Now here's the eye in question. And we've got a very confusing wavefront. We've got internals, but we've got corneals. So would you take this out, or would you try to do a wavefront guided ablation, or would you just treat the cylinder?
One thought I had, obviously we're looking at some higher order aberrations in the cornea. Would there be a place for just, putting a plano contact on a patient like this to see if that maybe solved at least some of the problems that might kind of help us direct where to go?
That's an excellent suggestion. And I think because, again, that will take away the higher order aberrations from the cornea. We did give her glasses to sort of simulate what correction of that diopter and a quarter of astigmatism, and she still felt it was blurry. So I told her that I thought that, unfortunately, with her cornea, the multifocal wasn't a match. And I went ahead and exchanged the lens. It's an older case, but this is her total aberrations, total now, before and after the explant. And there are still some aberrations, but you can see that with the monofocal, it was better. And the aberrations are a combination of a large pupil and her cornea. Arthur, you might have done a wavefront guided ablation for her.
You read my mind, David. I would have done a topography guided ablation and just got the cornea as smooth as possible, because even if that didn't resolve the problem, it would still make the exchange probably that little bit more effective. But I think Jesse's idea of doing a hard contact lens fit would be a very good idea. We do that quite often to try and help us figure out what the right way is to go.
Right. So we said step number one is we'll take out the multifocal because I didn't, and she basically was saying, I don't care about glasses. I just want to see clearly, and often we see that changes their motivation with further corneal surgery being an option. But she, in fact, she was fine with that. She was happy, and you can see that there was enough improvement, and she at that point didn't want anything else done.
I found.
Go ahead.
I was going to say I found that
my slides though. Yeah. Go ahead.
I was just going to say I found that with some of these aberrated corneas, putting a monofocal lens like an aspheric lens, you do get some increased depth of focus too. So some of these patients, I'll often say, look, let's hold off on the multifocal lens. Let's see. I don't guarantee anything, but I found these patients sometimes with J2, J3, and without any correction for near. So you may be surprised.
Great. We can take down my presentation, and we have a number of questions. So let's try to ask the panel these. First of all, where can I find iTrace University? How can any book for dummies on this? So if you go to the 20 Happy website under non-CME programs, you'll see a list of sponsors. If you click on Tracy, you'll see all of the links to that, and that will take you to their website. And I think that's actually a good way because there are some very excellent lectures there, and that's a good way to dig further. Let's see. How reliable is the iTrace refraction with the multifocal lens? Because many standard autorefractors don't work well with multifocals. And this is a question from Switzerland. Anybody want to take that?
Yeah, it can be quite tricky. Mostly I find it quite accurate. It's certainly good on toricity, but it can be tricky. And you just need to use your manifest refraction in conjunction with it to help you make the decision.
Right. How does the iTrace compare to the HD analyzer in terms of its capabilities?
So they measure two different things. The iTrace measures wavefront aberrations while the HD analyzer measures internal scatter. So they're measuring two different things and they're very, very complementary. I think the iTrace probably has more functionality given how good it is with the toric check, and it's got the value pre and post-op, and it's got the refractive power. But in the odd occasion, the aberrations can be low, the refraction can be spot on, and the patient's still unhappy. And then you can see from internal scatter where the problem's lying. And sometimes it's in the tear film. So it's a very useful tool too, and very complementary to the iTrace.
Because remember, the iTrace has a topography, placido, and ray tracing technology, right? So the HD analyzer uses double pass wavefront, and that will give you MTF with a point spread function, and then that function, the ocular scatter index, but it's all based on that point spread function and how it calculates the OSI.
Yeah, and where I use the HD analyzer is the surface for the tear film job of understanding the tear film instability.
So a related question is, if you could only choose one device in addition to biometry, what would it be? Would it be the iTrace, the Pentacam, the Galilei, or some other device? So that's a common one, right? We don't, we have space is a problem, footprint is a problem. Where do you put all these things? So one only device, what would it be and why?
I think, look, it's a tough question because I do use tomography. I use a Pentacam, I use all OCT, et cetera. So I think we all do that for the most part. But if there's one device, I think the iTrace is my other device besides the biometer. I think the amount of information that you can gather to understand the actual overall optical quality of the system in general, and to allow us to make decisions pre and post, I think it's just so invaluable. And I think that with my biometer, 99% of the time I can get away with understanding what's happening.
I would agree. I think the value of the iTrace post-operatively too is just so great compared to some of the other devices that we use.
I would agree with that too. And I think the main reason would be that some of the information that I get from other devices, like the Pentacam for argument's sake, I use it on every single patient. But things where it's really helpful, like the AC depth, I can actually see on the slit lamp too. So the iTrace often shows me things that I didn't anticipate or didn't understand. And for that reason, and for the fact that the patient can understand it so well too when they see the DLI, it would be my second instrument after a biometer.
Yeah, I think we would probably all agree that everyone should be doing topography if you're doing cataract surgery. And what I like is that this is a topographer, plus you get all the wavefront and the ray tracing on top of that. And we've heard about the toric, the pre and the post evaluation, but it's the same footprint and it's the same amount of time to acquire the data, and you just get so much more data. Even if you choose not to do a lot of multifocals and don't use it all, just to be able to diagnose whether it's an optical problem in the cornea or internal is so valuable. Is there a way to, yeah, go ahead, please.
Last point I make is the education part of it. I think there's no other tool that I have in my disposal that can allow me to properly educate a patient, whether to obtain a toric lens or multifocal lens or not. As Jesse mentioned, sometimes no, for you, a standard monofocal lens is the best option for you. So, and to be able to educate them in an efficient manner, I think there's no other tool that gives me that.
This is an excellent question. Can you use this to help with an unhappy multifocal patient to tell you whether you should do a YAG capsulotomy? In other words, does this really help us in terms of PCO?
That's quite a tricky question. I think if you are very familiar with the IOL, you start getting an idea of what the particular multifocal does in terms of aberrations. And if you see additional noise, you could conjecture that that would be PCO. I think what really helps there is the HD analyzer. You can see this increase in scatter. I know what the scatter values are from the IOLs that I use. And if it's more than that, I know it's the capsule. So I think it can, but I don't have enough experience yet for that particular function.
We actually published a paper, Arthur, with the HD analyzer, but also with the iTracy. Sometimes you can see changes in the opacity map.
Yes.
Right?
Yeah.
Right. When it's blocking light, it will be white on that opacity map. So it's another function. It gives us a lot of information.
Good point.
But I think it is helpful in terms of at least ruling out corneal aberrations. Again, I mean, it goes without saying, but sometimes unhappy multifocal lens patients are, giving you symptoms that, as you said, Karoline, sometimes can be a little bit difficult to pin down. So it at least helps you rule out that it's a corneal-based issue, and you are looking at something related to the lens or possibly posterior capsule. So I think it's helpful, at least in that regard.
We have another good question. How does the iTrace compare to the OPD, which also measures aberrations and separates internal and corneal?
I've used the OPD3 as well as the iTrace, as well as the Topcon KR1W, and they're all fantastic devices, do a similar thing. Why I really like the iTrace is the sequential laser beam, so I'm pretty sure that the wavefront is accurate. And what I really like, as Paul said earlier, is the educational aspect. The DLI is just so helpful. I find that an amazingly useful tool. So for me, it would still, of the three devices, be the one that would be my go-to.
Great.
And also with the iTracy, you can look at the wavefront. You can measure depth of focus curves. There's a lot of different functions and things that you can do, right? The OPD is just clear-cut cornea internal, but all the different functions with the iTracy toric check, DOF curves, and again, you can use that to teach and show your patients and counsel your patients.
But I think these are excellent comments. I think regardless, just to be able to look at higher order aberrations, which is a way to look at visual quality and what kind of contrast the patient is getting, that is so empowering. And again, I just looking back all the years practicing without this data, it's really, you're in the dark because you just can't see it in the cornea. At least the macula, I can see half of the time what the pathology is there. But you even look at a topography as we've shown today, and you don't always appreciate the imperfection from that. Well, I think, we've gone over, but I want to thank the audience for staying with us after a long morning. I want to thank Tracy. I want to thank this outstanding faculty. It's an international faculty, and they can't really carry a tune as well, but they know what they're talking about. So hope everybody enjoys the rest of your weekend, and we'll see you in 2 weeks for Module 5 of 20 Happy.
Thank you, Dave. Thank you all.
That's great.
Bye-bye.
Thank you all.